Sir, voice is not coming.
Sir, I think you are muted. You have kept your mic muted, sir. Sama, sir.
Sir, Dr. Samal is coming or not?
He's joining, sir. He's joining.
Okay, okay.
Yes, sir has also joined.
Sir, good evening, Dr. Sharma, sir. Dr. Burma, good evening.
Good evening, sir. Good evening.
अरे पूरा दाढ़ी बाड़ी बढ़ गया, पूरा बढ़ा दिया उसका। क्या रोजा रख रहे हो क्या?
हाँ? नहीं रोजा वोजा नहीं सर, पुरानी दाढ़ी है, ज्यादा बढ़ गई।
Yes, Samal sir, shall we start the program, sir?
हाँ sir.
If you are ready. Yeah, I think sir about 90% panelist and moderator has connected, so we will start the program, sir. Dear doctor, we are delighted to invite you for the Standing Heart Expert Summit on MRI in heart failure. I heartily welcome our moderator, Dr. MP Samal, DM and DNB card, FACC, FSCI, and FACP, giving his services to Apollo Hospital, Bilaspur. And I also welcome all expert panelists, Dr. Yushi Sharma, Senior Consultant Physicians from Saket Hospital, Janjgir, and Dr. Girdhar Patel, Consultant Physician from Gupta Hospital, Dr. Naresh Shah, D. Diabito from Durga Devi Hospital, and Dr. Pradeep Verma, Senior Consultant Physician from Varman Nursing Home, Bilaspur. Apart from that, sir, Dr. Saurabh Goyal, Consultant Physicians from MD Hospitals, Raipur, Chhattisgarh, Dr. Rohit Kumar Tated, Consultant Physician from Siddhivinayak Hospital, Kondagaon, and Dr. Animesh Chaudhary, Consultant Physicians from Apollo Clinic. Sir, over to you, sir.
Hello. Hello.
Sir.
Who is presenting?
Samal sir is presenting the slides.
मेरा तो moderator दिए हो. Who is the presenter?
Should I present the slide, sir?
आप present करो. आप तो moderator रखे हो. Present मैं कैसे करूँगा?
Okay, sir. Okay. Just a minute. I am sharing the slides.
Okay, let me share the slides. Leave it. Hello.
Yes, sir.
Okay, you share the slide. Let's see. Can you give me the slide sharing option?
Hello, Rhythm Tech Solution. Hello, Rhythm Tech Solution. Can you make Samal sir as a host? Sir, are you able to see the slides? I have shared the slides, sir.
Yes.
Just a minute, sir. I'm just
Make a
zooming this.
presenter mode. Make a presenting mode.
Yeah, sir.
Okay. Good evening, my seniors, dear friends. So I'll be sharing some points about the MRI in present treatment for heart failure management. As you know that heart failure, 4 pillars of management. One is the SC inhibitor or ARB. Of course, the ARNI has scored over the SC inhibitor and ARB because now the ARNI is the standard mode of treatment for heart failure, for LV dysfunction and heart failure with reduced ejection fraction. No more we should try the SC inhibitor first or ARB first, then switch over to ARNI. So you can go straight forward to ARNI as a stand class 1 indication for the treatment point of view in heart failure. Second line of drugs for the heart failure is the beta blocker. Of course, the beta blocker is the first drug you should start in the heart failure. Second is the SC inhibitor, ARB or ARNI. Third is the MRI. MRI is, the heart failure is due to the hyperaxis, aldosterone axis. So you have to neutralize that aldosterone axis by the mineral corticoid antagonist. So fourth is the more hyped anti-diabetic agent is the SGLT2. So these are 4 pillars for the treatment of heart failure. Above the 4 pillars, you can say that heart rate reducing drugs like ivabradine, which is another 5th drug you can add if your heart rate is not controlled for heart failure manager. So after the 4th drug, you can add the 5th drug, which is the heart rate reducing drug like the ivabradine. So next please. So as you know, next please. Next. So the MRI, the placement and utilization heart failure, we'll be talking about few words about that. The hyperkalemia, is it really concerned in the practice and to create awareness for the physicians for MRI. So the only drawback of MRI is the MRI cause retention of potassium and leading to hyperkalemia, and hyperkalemia, that causes a lot of cardiac events and systole and all these things. So that is the only fear of that. Everybody should fear that. Patient, normally the heart failure patient takes a lot of drugs. So like ARNI is also cause hyperkalemia and deterioration of renal function. So the global heart failure epidemiology, if you got that, next please. So prevalence of heart failure, 26 million people worldwide, 1 to 2% of adult population heart failure developed in the countries. Prevalence increases with age. I think by 2030, so the heart failure population will grow more than the cancer population, because we have increased the longevity of life. So heart failure will be the major killer worldwide. So 8 to 10 million people present in India, and 1% of total population, or about 8 to 10 million individuals in India. So annual incidence is 0.5 to 1.8, and mortality of course 1.1 to 1.16. Next, please. So what is the percentage of heart failure patient approach daily to us in stage 2, stage 3, stage 4? How many heart failure patients go undiagnosed in India at an early stage? So what are the diagnostic prognostic tools used by the heart failure patients? Normally clinics, everybody in our clinics, every day we found the patient comes with shortness of breath, but all of us do not have a facility to do echocardiogram. So many times we miss the heart failure patients. He may be a heart failure, or we can say the compensated heart failure, in which patient is really asymptomatic. But if you do echocardiogram, you find a patient has a LV dysfunction. Sometimes patient has a LV dysfunction, but his symptom is not signs of heart failure, that he doesn't have a pedal edema, he doesn't have a shortness of breath, but he may present with other symptoms like thromboembolism, arrhythmia, and renal dysfunction. So these are patients who normally we may overlook, we may miss in our diagnosis. Next, please. So the serum potassium, next please. So before starting any heart failure, anti-heart failure medications, like as I told you, the standard anti-failure medications like ACE inhibitor, ARB or ARNI, then comes the beta blocker, then comes the ARNI, or lastly the SGLT2 inhibitor. The beta blocker also cause retention of potassium. Beta blocker, ARNI or ACE inhibitor, it also cause retention of potassium, and basically these are nephrotoxic drugs, and also the MRI. So what should be the standard protocol? At what level we should withdraw the drug, but what level we should not bother that, no, we should continue the drug, do not bother about the potassium. Next, please. So we should know that parameter wise, what should the standard potassium level, above which we should not advise all these drugs, so that it should not be hamper the patient's vital functions. Next, please. So MRI is recommended to reduce the risk of heart failure, hospital patient, and death. It is no doubt is a class 1A indication, and MRI may be considered to reduce the risk of heart failure, hospitalization, and death. Is a class 2. So overall, the MRI like a mineral corticoid antagonist like aldosterone or epinephrine. So these are spironolactone, and these are epinephrine, spironolactone. These are helpful in reducing the heart failure, hospitalization, and reduce the mortality. So next, please. So the same thing in the line, you see that ACE inhibitor, ARNI, beta blocker, MRI, and SGLT2. These are all in a same line. So that means you can start all the drugs in a one time. No need to wait. Beta blocker should be start the same time as ARNI, same time as MRI, same time. So previously we thought that we should go one by one. However, you can start all the drug at a one stage. So whenever you feel that patient creatinine is normal, urea is normal, potassium is normal, and his ejection fraction is low, you can start all the drugs at a time. And if the heart rate is not controlled, you can add ivabradine in the next stage. And even if that all the symptoms, patient is symptomatic, his QRS is wide, then you can send him for biventricular pacing. Even if patient is LV dysfunction, patient goes with not controlled with that, then you can put for left ventricular assist device, which is another thing. Patient can go for left ventricular assist device, and afterwards we can go later for cardiac transplant, even sooner or later. Next, please. So in our practice, how many percent of patients we use MRI? Of course, heart failure management. In my practice, I use 100% of the patients to MRI, like epinephrine or spironolactone, because the patients the drug shows mortality benefit and also morbidity benefits. So when do you consider starting MRI in patients with heart failure along with the accelerator ARB? Next, please. As I told you that all the drugs can be started step by step, or you can start all the drugs at a time. So use of MRI as early as possible on the top of the treatment, including acid inhibitor, ARB, or beta blocker. Preferably, if you are not starting on the discharge on episode of decomponent. Whenever you are discharging the patient, you should at least start the beta MRI, these heart failure patients. Following an acute fall of aldosterone in response to administration of acid inhibitor, the level of aldosterone rise again and indeed returns to baseline in almost all patients. So this phenomenon is called aldosterone escape. Even when the acid inhibitor is combination with the ARB, aldosterone levels remain uncontrolled. So aldosterone escape might promote the release of aldosterone 2, angiotensin 2, and positive feedback loop of stimulate the acid inhibitor. The progressive escape of aldosterone are thought to contribute to acid inhibitor resistance, whereby the effect of acid inhibitor become the blunted. So the beneficial effect of mortality decrease over the time, whereas MRI are liable to antagonize the deleterious effect of aldosterone, resulting in the beneficial effect of mortality. As you show that the whatever tell is that the aldosterone escape initially, it happens, but later once you start the MRI, this escape phenomena is neutralized. Next, please. So, spironolactone, epineuron, and LV systolic function. If you find this is a study, so that if you start early, then ejection fraction and LV dimension is reduced, and ejection fraction improvement happens in this group of patients. Next, please. So, now question comes whether this you should use the spironolactone or epineuron. How you choose these drugs? Honestly speaking, the spironolactone and epineuron, there is no absolute difference in mortality and everything. Only thing that epineuron has less gynecomastia and than this spironolactone. If it's a lady, then you can give spironolactone. If a male, to me, if your patient is male, if you want to give the MRI, then you choose the epineuron rather than this spironolactone. Next, please. Efficacy-wise, both are good and marvelous drugs, the spironolactone and epineuron. However, the epineuron has a less gynecomastia than the spironolactone. So, if you have male patient, you should be cautious of giving the spironolactone. It is better to give epineuron so that he should not get a gynecomastia. So, when to start and when to stop the MRI? So, you have to stop the MRI when the potassium level is more than 6. So, whenever you start the epineuron or MRI, you should have a baseline potassium level and you should have a baseline creatinine level. Because many times what happens, these patients have either CKD or LV dysfunction leading to high renal hyperperfusion of the kidney due to high kidney. So, you should, before prescribing the MRI, at least you should know that baseline creatinine level and baseline potassium level. And if it is normal, then start with 25 milligram of aldosterone and 12.25 milligram of epineuron. Vis-a-vis same, and you increase the dose to 50 milligram. Similarly, the epineuron to 50 milligram. Once the creatinine up to 1, the creatinine level is 5.4. So, if the creatinine level is more than 5.5, then reduce the dose to again 50 milligram aldosterone, spironolactone, and 25 milligram of epineuron. So, the same thing, rising trends, you stop it, and decreasing trend, you can titrate the dose. If the potassium level is more than 6, then you have to stop the drug. And if it is more than 7 and hemodynamically compromised, then you go for a dialyzing to reduce the potassium level. Next, please. So, what is the preferred dose? How does the titration carried out in the practice? As I told you, start with 25 milligram of aldosterone and 25 milligram epineuron. If the potassium after 2 weeks, if potassium level is normal or not rise more than 5.4, you can raise the dose to 50 milligram of aldosterone and 50 milligram of aplenolone. Similar dose, and if still patient is potassium level is not more than 5.5, then you can titrate up to 100 milligram of aldosterone and 100 milligram of aplenolone. Next, please. The same thing, the prevalence of hyperkalemia is 9.3% out of 54% truly related to MRI. So it may not be due to MRI itself. It may be due to other drugs like the ARNI or beta blocker also cause rise of potassium, and MRI also cause rise of potassium. The ARNI causes rise of potassium, and acid can rise of potassium. So you should not blame the drug like the MRI or aplenolone or aldosterone is the common, the spironolactone is the culprit. Rather that you should find that what is the culprit, you have to find out step by step. So once you stop the spironolactone or aplenolone, you should see that whether this potassium is still elevated or not. If it's still elevated, then you should know that probably the ARNI or beta blocker may be the culprit. Next, please. So as I told you that only 9.4% of the patient can develop the hyperkalemia due to MRI, but in our concept, we feel that probably it is a higher dose aldosterone, spironolactone, or MRI causing that. Hello. So, as you know that in our clinical practice, because we should know whether what percent of the patients we are treating with MRI and what percent of the patients developing hyperkalemia. Probably this question should have a panel thing in the on the switch mode. I don't know whether they have options for that. They should have options to click how many in our practice, but it is in our practice we found that normally is less than, you can say that 7% patients have a MRI induced hyperkalemia. So really it is not due to hyperkalemia, is totally, whichever patient you get a hyperkalemia is totally due to MRI. The very only 5 to 6% patient may have get a MRI induced hyperkalemia. Next, please. Next, please. So when to start, as I told you, when to start the aplenolone at least, or spironolactone at least post-MI patient before discharge, at least we should start. I don't know whether how many patients in our also clinical practice we never start the aplenolone or spironolactone before the discharge. But if you find LV dysfunction, you can discharge the patients. On the discharge, you should start the aplenolone or spironolactone in all patients with LV dysfunction. Next, please. Next, please. So in clinical practice, how early are MRI initiated for management of heart failure patients? As I told you, so the common consensus that before discharge, all the patients of heart failure at least should start the MRI. So that, as I told you, the MRI is a major rehospitalization and mortality benefit is there. So all patients of heart failure should be started with the MRI unless until they have advanced kidney disease or a high rise of potassium. Next, please. So the same thing, the diagram shows the first start the SN inhibitor or ARNI, beta blocker and MRA and DAPA or EMPA and loop diuretics is given because to relieve the symptom. However, the diuretics never improves the mortality benefit. It gives only symptomatic benefit. So again, with all the drugs, if ejection fraction is less than 35% and QRS is more than 130 millisecond or 130 millisecond, then you can switch him for the CRT. And if patient has a ejection fraction less than 35%, QRS less than 30%, 130 millisecond, and patient can have a ischemic background, then you can put in a ICD. So, and ultimately, of course, the cardiac transplant is there. So, if patient is not improved with the Aldosterone patient, you can put into the ventricular assist device. After ventricular assist device, you can go for a cardiac transplant. Next, please. So, these are the questions for all of us in our practice. Any other indication apart from heart failure who are MRI are used? So, I think a lot of people, they are using the spironolactone in other indications. So, renal cause is there and refractory hypertension. If your hypertension is not controlled, you can use the spironolactone. And of course, the heart failure with preserved ejection fraction, like a condition, you can use that spironolactone or epinephrine. Heart failure with preserved ejection fraction, you can use the epinephrine or spironolactone. Next, please. I think that is the end of the slide. So the topic is open to all the delegates, and I hope we enjoyed the topic. Let us discuss. Any doubt is there, we will be happy to answer.
Sir,
Yeah.
I want to just ask you one thing. Which beta blocker is best in the heart failure?
See, the widely studied beta blocker is the carbidiol, but the newer beta blockers like bisoprolol or that you can use the bisoprolol because it has also a very good effect, and it has also the antioxidant effect. But nebivolol is a beautiful drug. Overall, if you think that nebivolol is the highest beta blocking capacity, but the carbidiol has been widely used because it has an alpha negative effect, so that it causes also peripheral vasodilation in addition to the positive cardiac effect. So it cause also the vasodilation. Whereas the nebivolol and bisoprolol, they don't have a peripheral vasodilatory effect rather than purely cardiac effect.
If the patient has already heart failure patient has already in hypotension, should we use a beta blocker to control the heart rate?
See, the ultimate aim is to reduce the mortality. So if patient is in hypotension, you have to titrate the dose of beta blocker, because beta blocker is the only drug reduce the mortality benefit, because heart failure is a arrhythmic milieu. So patients normally dies of arrhythmia rather than pump failure. All the heart failure patients, they die of arrhythmia rather than pump failure. So you have to neutralize or reduce the arrhythmic milieu. So that is why beta blocker is the class 1 indication in the first drug of the 4-pillar drug. If you see the heart failure drug treatment, the beta blocker is the first drug of the 4-pillar drug of heart failure.
If the patient has a higher due to CCF, due to MI, then what should we use the Lanopsin and digoxin or beta blocker, or is there, can we use in hypotension case of CCF in spite of beta blocker, can we use the Nanoxine?
You see, Lanopsin has never used. What is the role of Lanopsin? Lanopsin increases the contractility, right?
Okay.
But the myocardium, ischemic myocardium wants a relaxation rather than contraction. You want to beat a tired horse. Your MI or myocardium is a tired horse. So you don't want to beat a tired horse. Digoxin is a beating. It will beat your myocardium because it increases the force of contraction. It increases the myocardial oxygen consumption. So you should give relax to the myocardium rather than beating to the myocardium. So the Lanopsin is nowhere in the treatment of heart failure in any point of time. Lanopsin is only indicated when there is atrial fibrillation to control the rate.
Okay.
So it is no more heart failure treatment drugs unless until patient has a atrial fibrillation.
Okay.
So if patient is atrial fibrillation, then you should use Lanopsin.
Okay.
But otherwise, Lanopsin has absolutely no role in heart failure.
At how many times we should check the potassium level if we are using the MRA?
At least after 2 weeks, I should check the potassium, and for initial 3-4 weeks. Then after once you know the vital and all is stable. So every month at least you should that 4 to 6 should be the potassium level. Because we are using very low levels of MRI. Normally you should go up to 100 milligram of MRI. That only gives positive benefit.
Okay. Should we use it for lifetime?
Yes, these are drugs for lifelong.
Okay.
ARNI, beta blockers, and MRA, at least these are used for lifelong. It may reduce the dose according to your clinical signs and perception and improvement of functions.
Okay.
But these are drugs for life.
Thank you.
Dear sir, my humble request, can you switch on your videos for a few minutes?
Share. Okay.
Everybody has videos.
Okay. Are you able to hear my voice?
Sir.
Namaskar.
Namaskar.
Can we use ARNI and epiluron or this is spironolactone together in heart failure with reduced ejection fraction?
Yes, sir. This is the one of the drug of 4-pillar drug. You have to.
So then we have to give this beta blocker and then ARNI instead of AC or ARB, and then again these diuretics, potassium sparing means, and MRA.
Yes.
And if the ejection fraction is less, can we use Nanoxine or evaporatin to reduce the heart rate?
Sir, Nanoxine has only indicated when atrial fibrillation is there.
Atrial
Atrial fibrillation is not there, don't use the Nanoxine.
Okay.
Use the beta blocker or use the evaporatin to reduce the heart rate.
Most of the time we have seen that the patients who come with heart failure with reduced ejection fraction, they have got low BP. Then how to start ARNI in that condition, because it contains valsartan along with so it may reduce the blood pressure furthermore. So in what dose we should start?
The standard dose which has been used in the paradigm heart failure, which is the biggest landmark, you can say that the trial which has been prematurely stopped because of its positive effect. So the paradigm heart failure trial shows that up to the blood pressure of systolic 90 millimeter of mercury, you can start the 50 milligram of twice daily.
Okay. And what about if the patient is having low potassium? Can we continue it for a very long time?
If potassium is low, then you can safely give the spironolactone and safely give ARNI, because that these drugs can increase little bit potassium also. So you can give safely.
What about this isosorbide or hydrolazine using this?
Isosorbide, hydrolazine combination, the isolazine is available. However, the mortality benefit is very less with isolazine, but still some positive benefit is there in isolazine, but it has no absolute mortality benefit.
Can we use this isosorbide, or nitrate in those cases which are having dilated cardiomyopathic with ischemic pathology?
Yes, because of course, as you know that the nitrates are venodilator, obviously that cause better, but hydrolazine is a drug which cause arterial dilatation. So it reduces the afterload. So it helps in easy emptying, it reduces the load over the heart because it is a afterload reduction drug. So just like your beta blocker, like carvedilol, it causes a peripheral vasodilatation also. So you can use the isolazine if the blood pressure is tolerable, then you can use the isolazine. It also has a positive impact on the easy emptying of the heart.
Okay. Thank you, sir. Thank you very much. Thank you.
Sir, can we use MRI in diabetic nephropathy or nephrotic syndrome?
Yes,
Yes,
all
yes,
the
yes.
nephrotic syndrome, all the, because this MRI is a drug, that cause. Don't think how it is working in the kidney. It is working in the heart. It reduces the fibrosis of the myocardium. It is a totally reverse remodeling drug.
Sir, as we use beta agonist for the hyperkalemia treatment, because it cause the influx of potassium, so are the beta blocker can cause hyperkalemia in the same mechanism from the efflux of the potassium from the cells, as the beta agonist is using in the treatment of hyperkalemia. So beta blocker can cause the hyperkalemia, and can it also add up if we use the ARBs or ACE inhibitor with the spironolactone and beta blocker? The chances of hyperkalemia is high.
See, beta blocker itself can cause, hyperkalemia. There is no doubt of that. And beta mimetic drug, as you rightly told, when we got a hyperkalemia, we give salbutamol, salmeterol, inhalation, nebulization, like we use in bronchial asthma patient. So whenever you get a hyperkalemia, we nebulize the patient with salbutamol. So salbutamol is a beta 1 agonist drug, right? So it causes hypokalemia rather than hyperkalemia. So you can use that. But if you find that the patient is in requiring beta blocker, at least you should not use the beta 1 agonist drug in heart failure, because our purpose is not solved. We want a beta negative.
Sir, one question is from my side. Some patient complaining of sexual dysfunction in heart failure patient. So we can give to him phosphodiesterase inhibitor?
Absolutely contraindicated. Absolutely contraindicated. Because once in a while, heart failure, phosphodiesterase inhibitor is a very bad impact on ischemic heart failure drug. If patient is giving in nitrates and if you are giving phosphodiesterase inhibitor, it is absolutely catastrophic. Patient will suddenly, arrest during taking the phosphodiesterase inhibitor. So for heaven's sake, don't use that phosphodiesterase inhibitor in patients with heart failure. You never know, he may be getting a nitrate. These two drugs are deadest combination. They are really should not be used. Phosphodiesterase inhibitor and nitrates. Because heart failure patients, sometimes they take nitrates to reduce the heart failure symptoms, like a ischemic heart disease and all these things. Because everybody writes monotrates, sorbitrates, and all these things.
Yes.
It is absolutely contraindication.
Thank you.
Hello, sir. Hello.
Yes, yes.
Sir, what all parameters we need to monitor on starting this drug in a follow-up patient, and for how long we can give this to the patient, sir, the drug?
Normally, see, these are, as I told you, the drugs, all our drugs has been prescribed during study period. None of the trials has shown that you have to stop the drug after the, positive. Why you should not stop the drug? I'm telling you. Heart failure is a progressive disease. Suppose आज आपके पास 50 mg of myocardium survive मतलब viable है. During 5 years, you may get a 10 gram of viable myocardium because it is an ongoing apoptosis process. Our aim is to halt this ongoing apoptosis so that positive remodeling should not be there. So you should go for a negative remodeling. If positive remodeling will happen, then due course of time, there is a progressive fibrosis, progressive metalloprotein deposition. So it is a progressive disease. We have to stop it. So it may not improve the status, but it should not be deteriorate. So these drugs are prescribed for life.
Sir, what is the role of BNP in the treatment of the heart failure patient?
Yes. Why do you do BNP? You see, BNP is liberated from stressed myocardium. Suppose if patient has a volume overload or a myocardial infarction or patient has a dilated cardiomyopathy. So the chamber is started dilating. Once get dilated, the BNP is liberated from their myocardial cell, ventricular myocardium cell. So that indicates that the LV is dilating. That means some process of insult is going on in your myocardium. So that is a indirect evidence, it is a marker of myocardial distress, or you can say the myocardium is damaged. So if you estimate the BNP, then suppose a patient has a 200 BNP, some patient has a 5,000 BNP, some patient has a 10,000 BNP. So those have a 10,000 BNP, definitely their myocardium in jeopardy is more. So the LV is more dilated. So you have to focus on that.
Thank you.
So when you start the ARNI, then you should know also how efficiently you are treating, your treatment is going on. If BNP started falling, that means your treatment is going on okay.
Sir, apart from
one question more.
creatine and hypotension, there is any contraindication for MRA in heart failure patient?
I don't think any contraindication except hyperkalemia. That is the only contraindication for MRA is the hyperkalemia. So if hyperkalemia is there, of course the drug hypersensitivity it is there. Second is if patient is hyperkalemia or advanced kidney disease, you should not give at least MRA. Advanced kidney disease, they have a propensity to develop hyperkalemia at any point of time. So you know that she is a hyperkalemia. Potassium excretion is not there. Every time, where does potassium come? Potassium comes from the intestine, from the stomach, peptic juice. Potassium comes from peptic juice and kidney excrete the potassium in the urine. So if advanced CKD, the potassium do not get excreted from the kidney. So whichever gastric juice gives the potassium, so definitely it is accumulated inside your body. So it cannot excrete. So the potassium comes from your food and from your gastric juice.
Okay, thank you.
Sir, any prognostic tool or markers in the heart failure patient to do monitor?
BNP or anti-pro-BNP is the best marker for that. So now other markers are, you can say that the LA volume, LV volume, echocardiogram, you can do that. LV muscle mass, LV ejection fraction, that will give time to time you can do that because that is a non-invasive, non-harmful and more or less non-expensive also, because if your patient, you are following them, you should know how you are treating. So echocardiogram doesn't cause expense of I think 10 rupees or 15 rupees if you are a echocardiogram doing by yourself. How does it matter? It is hardly it matters if you are doing echocardiogram by yourself. If you are sending for a cardiologist, then obviously fees matter. If you are doing yourself, it doesn't matter. Hardly ever it is 100 rupees, it may be costing 20. So that is the best indicator to know that whether LV function is improving. And second, as a clinician, the clinical parameter is also what class he was there, what class he is now, 6-minute walk, and LV function, protein, bilirubin, creatinine, JVP, all edema, all these things. You can measure the weight.
Okay.
If you are a good clinician, you can know that these are the parameters. He's, giving you immense pleasure that yes, my patient is improving.
Yes. Yes. Okay.
So now a lot of devices are coming. If patient is getting water retention, so new generation device like CRT. So the biventricular pacing, they put a device. Now the device called flow monitor, they keep it in the pulmonary artery. If your volume retention is there, it give an alarm. It give an alarm to you. It give an alarm to your patients. It give an alarm to your physician that your patient is returning water. Tell him to come to you.
Yes.
देवेंद्र
सर कैसे हैं आप?
हाँ ठीक बढ़िया है
Yes, sir. Yes, sir.
आप समाप्त करो ना ठीक है
हाँ क्षमा करें.
Yeah, definitely.
Hello,
Thanks,
sir.
our
I am
moderator
Lekpal
for giving
Shrivastava
us
sir
such a
from Sipla, sir.
knowledgeable speech.
Hello, am I audible, sir?
Yes, sir. Yes, sir.
Yeah.
Tell me.
Yeah, sir. Thank you so much, sir. I think like Devendra requested me, actually there is a poor network at his end, so I just wanted to conclude, I think, the session. I was just listening to the each and every conversation. I think the basic purpose for this meeting that we have kept, I think it has come with a very significant approach. I think the one-to-one discussion, the basic core agenda for this meeting was this only. We also looking forward for the entire like consensus so that we also can work upon and strategize something at head office, that what things to be presented for the physicians going forward. I think you also, sir, MP Samal sir actually decoded the role of MRA in the management of heart failure. And it has been seen that, sir, you would agree with me the fact that in nowadays, like these are the 4 pillars which has been like class 1 indication, maybe like ARNI, SGLT2 and beta blocker and MRA. MRA somewhere has been less talked into the meeting discussion point of view. SGLT2, ARNI, these topics are being very extensively taken during the academic meetings also.
So you people are not sponsoring the talk. The SGLT2 people are there coming to the market, so they are putting their voice. So you should have a good, voice in the well, because MRI is a old drug. It is not a
Yes,
new.
sir.
SGLT2 is a new drug. That is why they are putting heart failure. Every day they are talking about the SGLT2 in heart failure.
Rightly said, sir. That's the reason, sir, we have identified this gap, sir, at our end. And we being like into this therapy, actually we have very significant presence, sir. And that's the reason, sir, we are creating this platform.
Because
And going
very few
forward,
company have a spironolactone and epinephrine. That is why this noise is not there.
yes, sir.
Okay, I think thank you all. Thank you, Sarma sir. Thank you, Verma sir, and other delegates. So thank you for your kindful listening. So I think we should conclude.
Yes, sir. Thank you so much, sir, for your valuable time.
Thank
And
you, Shidla. Thank you all.
Thank you very much. Thank you.
Thank you, sir. Thank you.
Thank you. Good night.
Thank you very much.